start with the first OSCE. First OSCE is a picture. There's a typical name to this particular sign in the clinical practice. I want to know from the audience what is the name of this particular sign.
This sign is known as Trocher sign, sir.
Okay, very good. So this is a Trocher sign, that is the left supraclavicular lymph node
Lymph
enlarged.
node element.
Can you tell me which level of lymph node this is?
Level 4.
Yes, very good. This is a level 4 lymph node. So which are the malignancy we would likely to find a left level 4 isolated lymph node? Now, when Trocher sign is called when you have a isolated left level 4 of lymph node, which the pathophysiology of which is different from other cervical lymphadenopathy. So, can you highlight which are the malignancy where this are commonly found?
So particularly intra-abdominal malignancy like stomach and the bowel.
So it is the infradiaphragmatic malignancy and the right-sided thoracic malignancy, which manifest with left-sided level 4 cervical lymph node. Now, in contrary to the other head neck cancer where other level of lymph node enlarged and got enlarged, this is a particular peculiar because of the particular pathophysiology. So, can anyone highlight why this lymph node get enlarged in an abdominal cancer rather than other lymph node? Why particularly left level 4 lymph node is got enlarged?
Due to close association with thoracic duct or interjugular veins.
Okay, with what close association? What is the exact pathophysiology? How come this tumor cells comes into the left neck directly from abdomen? So what happens, it's a very important pathophysiology to know, is that when you have this abdominal or right-sided thoracic malignancy, especially the carcinomas, which drains into the lymph nodes, they drains into the thoracic duct. And this thoracic duct, this particular thoracic duct drains into the junction of the internal jugular vein and your subclavian vein on the left side. So when the patient takes an inspiration, then there is a negative suction created inside the thoracic duct. So all the tumor cells get sucked into the junction at the IJV and left-sided internal jugular vein and the left subclavian vein. And the lymphatic from left level 4 lymph node stations directly drain into the junction just opposite to the thoracic duct on the same junction. So what happens whenever this negative suction is being created, the tumor cells directly lodges into the level 4 left-sided lymphatics, so and get deposited into the lymph node. That is why in intra-abdominal cancers, this lymph node get enlarged. Okay, this is your neck, and so the IJV is draining, and your subclavian vein, they are joining here over here. Okay, and they're forming the brachiocephalic, which is draining the right side and forming the IVC. This is like a venous drainage of your neck. Now, the tumor, the thoracic duct, which comes to the posterior mediastinum, comes here and drains into this junction on the medial side. Now, from the level 4 lymph node, which is in the left side, there is another lymphatic duct which drains into this, opposite to this. That is why whenever there is a negative suction, this vein get collapsed, the internal jugular vein, then this tumor cells from this thoracic duct directly lodges into, rather than going into bloodstream, directly lodges into this lymphatics of the level 4, and that get enlarged, causing a troissus. Okay. Okay, we'll coming to the third OSCE. This is a picture of a specimen. You have to identify the specimen. There are two organs which has been dissected. Any idea what operation has been done? Any organ, any one of this organ you able to identify?
Liver.
is positioned anatomically. See, this organ is in the left upper quadrant.
The spleen, actually, this is the.
So what can be the specimen? There is another organ which contains the whole of omentum, looks like a part of bowel.
Left hemicolectomy.
So this is a gastrectomy with a splenectomy. Okay. That is, so we want to know what is the current day indication of gastrectomy along with the splenectomy. Do you remove a spleen routinely in gastrectomy nowadays?
No, sir.
Okay. So there are few specific indication in which you remove the spleen and during gastrectomy. Can you tell me what are the indications? Okay, if the tumor is directly infiltrating the spleen, then you have to remove the obviously the spleen along with the stomach. If there is a tumor on the greater curvature on the fundus, so there is a high chance that splenic hilum lymph nodes are involved. So if you cannot clear the 10D lymph nodes, so that is the time you should remove the spleen. And the third is when you cannot get a clearance, you have a substantial chance of level 10D splenic hilum lymph node involvement, proximal gastric cancer, and you cannot remove the lymph node without sacrificing the vessels of spleen. You have to remove the spleen along with the gastrectomy. Okay. So now tell me, what is a D2 gastrectomy?
So clearing of station 1 to 16 lymph nodes.
1 to 16, my God.
No, 1 to 12, sorry, if I'm not wrong.
12. So basically, D2 is related to lymphadenectomy of gastric cancer, right?
Yes, sir.
So there are two types. One is a D1, in which you clear up the immediate perigastric lymph nodes. But if you remove along with the perigastric lymph nodes some other stations, that is called a D2, the second order stations, that is called a D2 gastrectomy. So in D2 gastrectomy, how many lymph nodes should be removed, should be in the sample to classify it as a D2? Any idea how much? See, after the lymph node has been removed, they will be in the specimen, right? So you will not be able to always judge how much, whether all the stations has been removed or not. Now, that is why you need a minimum number of lymph node. If it is removed, that needs to, okay, standard D2 dissection has been done. So for stomach,
10.
it's not 10. 10 is for breast.
Okay.
So in D2 gastrectomy, we'll remove 1 to 6 node, that are the perigastric node, okay? Level 1 to 6, this is 1, 2, 3, 4, 5, 6. Along with that, we remove other nodes like the 7, the common hepatic artery, the hepatoduodenal ligament, the splenic proximal, along with the nodes. Sometimes we have to remove the level 14 also. Okay. So these are the extra nodes other than perigastric which you remove depending on the location of the tumor. Sometimes if the tumor is located proximally, the stations which will be removed in D2 is different from a lesion which is located distal. But D2 is clearance of second echelon lymph nodes along the perigastric lymph nodes, so that we have a better staging of this cancer. Okay. Okay. With coming to the fourth OSCE, you have to identify the procedure.